Well, a warm welcome to this talk. Now, we've expressed a lot of concern on this channel about the widespread distribution of mRNA vaccines, the toxicity of the spike protein, and the adverse events that are associated with that. But of course, we always have to give evidence for what we are saying. And when we review the evidence today, at the end of this video, you might be surprised that the COVID mRNA vaccines are still readily available and being distributed and being recommended. Now, but make your own mind up on that. Let me give you the evidence. So here we have the source we're looking at today. This is from a group called Zembo. Now, these are like library publications. And these are South African, a couple of South African medical researchers have done this. And what they've done actually is they've put together a lot of the evidence in these files here, and they go through many papers, and we're going to just briefly look at a few of these. The one on biodistribution, which we're looking at particularly, I think there's 54 references. We're not going to look at all of them, but just enough to really give evidence, which is overwhelming and in my view quite conclusive, that's still not being activated on or acted on by international regulators. It really is quite bemusing why this is not being acted on more quickly. Now, this is the paper here that we're looking at. This is the review paper, mRNA vaccine, biodistribution, persistence and adjuvant toxicity in toxicity library. Now, we're going to look at the biodistribution, the fact that this goes all over the body, and persistence, that it sticks around for a long time, more than 6 months, as we'll see in at least one paper. We're not going to look at the adjuvants today. That's a bit much for one video. So biodistribution, just looking at where it goes. Now, of course, the background here is initially we were told it stayed in the deltoid muscle. That's absolute rubbish. It doesn't. It goes everywhere. The lipid nanoparticles are systemically distributed, carrying their payload of messenger ribonucleic acid, which can go into essentially any cell exposed to the vascular system, pretty well any cell in the body, produce a foreign protein that goes onto the surface of the cell and will elicit an immunological response in that cell. And we'll be looking at specific examples of myocardial toxicity of this shortly. So research collection presents 54 peer-reviewed studies in this example that we're looking at here from this library collection. Wide distribution of, and they use vaccine in inverted commas there, the genetic preparation. Wide distribution of vaccine, mRNA and the associated spike protein. So we're looking at the distribution of the vaccine mRNA and the spike protein it produces, the toxic spike protein it produces, through human subjects and animal and human subjects. These articles confirm that vaccine mRNA and spike protein can reach tissues and organs, including the mRNA and the spike protein that the mRNA produces can reach the heart, unfortunately, liver, unfortunately, brain, unfortunately, lungs, unfortunately, placenta, unfortunately, umbilical cord, unfortunately, get into breast milk, unfortunately. We could go on. Lymph nodes, thymus, spleen, bladder, large intestine, eyes, adrenal glands, ovaries, sadly, yes, ovaries, testes, sadly, yes. So that is pretty convincing evidence. And the first specific evidence they give for this is for the Australian government, the Therapeutic Goods Administration. And you're probably going to be amazed. This was known in 2021, and yet the Australians authorised this. And I think we can assume that the British government or the British regulators had the same information. And I think we can assume that the Americans did, and the Canadians and the Kiwis and everyone. I think we're fairly safe in assuming that. But this one's from the Therapeutic Goods Administration. Now, this one's actually a PDF. I could just show you that briefly so you know I'm not making this up. This is from their non-clinical report. Yep, back in January 2021. They knew all this. Absolutely incredible. Let's look at a little bit of the detail. The concentration of radioactive lipid markers. So what they're doing is they're radio labeling the lipid capsules, the lipid nanoparticles, so they can see them or detect them. The concentration of radioactive lipid markers reach peak levels in plasma between 1 to 4 hours post-dose and distributed mainly into the liver. This is what they said in 2021. Distribution mainly into the liver, adrenal glands and spleen and ovaries after over 48 hours. So this was known in 2021. The full report is there. Look, don't take my word for this. It's all here. At least quite a lot of it's here. I'll show you that some of it's not, but the full report is there. Also listed as tissue distribution positive, so basically everywhere. Adrenal glands, unfortunately, bladder, bone, the femur, brain, eyes, heart, kidney, colon, small intestine, liver, lungs, lymph nodes, ovaries. Ovaries again concerning there, that they knew that in 2021. These are in rat models, by the way, they're not in humans. Although the first list was in a combination of both, but these are from rat studies. But the whole point of doing this is to find out if it's going to be dangerous to humans, I would have thought. And it goes on. So evidence of systemic distribution. Good word here would be unequivocal, unambiguous, definite, proved, conclusive. No ambiguity. And there's some also interesting, this paper from the TGA here, also a few other interesting points I want to raise from it that are in this paper. And I've taken a couple of screenshots. This one here, for example, is quite interesting. And I'm sure you'll find these points particularly riveting, if we're allowed to read them. Just a few other screenshots from the TGA paper. This is also obviously quite interesting. This point here, for example, I'm sure grabs your attention. Or these points here. I mean, this is ridiculous. This is 2024 and we're still got all this redacted data. Why is all this data redacted? Why aren't we allowed to see it? Answers in the comments. Right, moving on. Let's look at some of the other papers. We'll move on, I think, now to this one. No, this one here. So moving on to this one now. This is in the Journal of Immunology. Now this one is this is saying, these are the links, by the way, do check them out for yourself as always. Results demonstrated induction of circulating exosomes expressing spike protein on day 14 after vaccination. Now, the reason I put this in is the results here demonstrate the induction of circulating exosomes. Now, these exosomes, these are lipid-bound particles actually produced by cells. So as well as the original product being biodistributed all over the place, we now see that the mRNA has caused the production of spike protein in exosomes, the body's own cells, adding to the systemic circulation. So what have we got to worry about here? Well, first of all, there's the initial lipid nanoparticles introduced from the vaccine, and then, hey-ho, the body will make some more and circulate spike protein through its own exosomes that the body's own cells are producing. So two ways to have circulating spike protein. Actually, the first one is circulating mRNA. The second one is spike protein. There you go. Systemic distribution of that. This next paper here, this is... yeah, let's look at this in a bit more detail. It's a little bit complicated. This is intramyocardial inflammation after COVID vaccination. An endomyocardial biopsy proven case series. Right, so this is in the myocardium, within the myocardium, intramyocardial inflammation after COVID vaccination, an endomyocardial. So what happens here? Endo is inside myocardium. So what happens here is they actually pass a probe via a vascular catheter inside the heart and take a snippet of the myocardium from inside the heart. This is normally used after cardiac heart transplants to check for rejection, but here they were using it after COVID vaccine. It's a very invasive procedure. Cardiologists do not carry out this procedure lightly by any means. And they did a comprehensive histopathological, so looking at the histology, in other words, looking at the disease in the tissues, histopathological analysis of this endocardial biopsy, endocardial biopsy proven. Yeah, so endomyocardial biopsy, get it right, EMBs, endomyocardial biopsy from 15 patients with reduced ejection fraction. Now, reduced ejection fraction means that the heart is not pumping out as much blood as it should. So the ejection fraction is the amount of blood pumped out per contraction. If that's reduced, there's a reduction in cardiac output, obviously a very serious condition potentially, depending on the amount of reduction. And clinical suspicion of myocarditis following vaccination with Pfizer, AstraZeneca, Johnson & Johnson. Now, these are the numbers of the vaccine involved. Now, immunohistochemistry, so looking at the immunology via the chemistry of in the tissues of these EMBs. This is the endocardial myocardial biopsies. Analysis reveals myocardial inflammation in 14 out of 15 patients. So the hunch was right 14 out of 15 times. There was myocardial inflammation. With a histopathological diagnosis of acute myocarditis in 2. Severe giant cell myocarditis in 2. Now, this severe giant cell myocarditis, obviously it means you get big cells, giant cells. But it's very rare. You get these large cells, but it's associated with heart failure and a remarkably poor prognosis. From the form that I'd heard about before, the death rate was about 70% in the first year. So what happened to these on follow-up, we don't really know. But very serious condition potentially. And inflammatory cardiomyopathy in 10 patients. Importantly, infectious causes have been excluded in all patients. These weren't caused by infections. The expression of SARS coronavirus 2 spike protein within the heart and the dominance of the CD4, that's the T helper lymphocytes. Inflammation indicates an autoimmune response to the vaccination. So again, what's happening here is that the mRNA is getting into the heart cells. The heart cells are expressing the spike protein. These immune cells are beating up the body's own heart cells, causing basically an autoimmunity where the body's own immune system is attacking the body's own heart cells. So again, evidence of distribution to the myocardium. This next paper here is this one. Let's look at this one now. And again, the links are there, so you know these are genuine papers. Long-lasting biochemically modified mRNA and its frame-shifted recombinant spike protein. So frame-shifted means that the protein that's actually made is different from the spike protein. The genetic code has like moved along one and produced a different protein. And this is concerning for other reasons as well. We don't want rogue proteins being produced or rogue mutations. Another cause of concern, but I'm not going to focus on that today. Recombinant spike protein in human tissues and circulation after COVID-19 vaccinations. Right. It was originally estimated that recombinant spike protein generated by mRNA vaccines would persist in the body for a few weeks. Now, we were told a few days initially, but a few weeks later. In reality, clinical studies now report that modified SARS coronavirus 2 mRNA routinely persists up to a month from injection. So the modified SARS coronavirus 2 messenger RNA that's given via the injections persists for up to a month after injections and can be detected in cardiac and skeletal muscle at sites of inflammation and fibrosis. So the mRNA is seen where there's inflammation, while the recombinant spike protein may persist for 187 days in blood. 187 days in blood. Now, if the spike protein, 187 days after the injection in the blood, that indicates to me that it's still being made somewhere, because that's an awful long time, and you would expect the body to break it up really quite quickly. So if it's still there after 187 days, I suspect it's being, that is, to me, I can't see any other explanation apart from ongoing production, which of course is concerning. The last paper we're going to look at in this series is this one. Here again, the link is there, so you know I'm not making it up. Playing dice with the spike. Let's hope our doctors don't play dice. Understanding the pharmacology of COVID-19 mRNA vaccines playing dice with a spike? ? Right, both vaccine-derived SARS-CoV-2 spike protein mRNA, so that's the mRNA to make the spike protein, and the resulting spike protein itself exhibit a complex pharmacology and undergo systemic disposition. So again, confirmation that it goes everywhere. Taken as a whole, this paper says, evidence strongly supports the possible link between inappropriate expression of spike protein in sensitive tissues and subsequent tissue damage. Personally, I don't think I've got any tissues that aren't sensitive. I'm quite attached to all of my tissues. So I think that includes all potential tissues in the body, to be fair. There's no non-sensitive tissues. What part of your body would you gladly give up? That's a rhetorical question. Obviously, the answer is no part. Right. Now, they give here a case of a woman suffering from Moderna COVID-19 vaccine-induced thrombocytopenia, which we know about. Penia, lack of thrombocytes, the platelets, lack of platelets in the blood. So with a 10 nanogram a mil vaccine-induced spike protein level in plasma 10 days after vaccination. Now, of course, that doesn't mean much until we notice that this 10 nanograms a mil is nearly 100 times higher than those reported previously. So this lady having the side effect, the adverse reaction, presumably from the vaccine, had 100 times higher dose than would be expected of spike protein, of vaccine-induced spike protein levels, the actual spike protein itself in the plasma 10 days after vaccination. 100 times more than it's supposed to be, or has been seen before, suggesting excessive vaccine-induced production of spike protein as a determinant of vaccine toxicity. So what this paper is saying is some people who suffer from vaccine toxicity are just producing way more spike protein than others because the dose is completely unpredictable. As this paper will go on and say, a comprehensive review of the literature recently discussed the role of COVID-19 mRNA vaccine-induced spike protein in adverse effects following vaccination. So here they're saying they think it's the COVID-19 mRNA vaccine-induced spike protein that's causing the adverse events. A major explanation of adverse events following COVID-19 vaccination could well be that the mRNA vaccines induce in selected individuals excess production of spike protein. And this is just a new paper. This one is actually no, this has been known since 2022. Some of these are 2024. But again, we've been saying this for a long time, that the dose is unpredictable. When you give drugs, you must give the right dose of the right drug to the right patient via the right route at the right time. And how can you give the right dose if you don't know what the dose is going to be? I'm going to give you some morphine here. It might be a milligram, might be 100 milligrams. Hey ho, whatever. Roll the dice, take your chances. You're up for a bit of a game of Russian roulette, aren't you? This is the antithesis of how healthcare should work, of course. For too long and or inappropriate tissues and organs. So too much spike protein is made, potentially for too long, or in inappropriate tissues and organs. And at the present, this occurrence is unpredictable. So it's unpredictable how much spike protein will be made, where that spike protein will be made, and for how long that spike protein will be made. And we've just given evidence for that combined with the systemic distribution. And yet these vaccines are still being advised by regulatory agencies. I would have thought they should be suspended until all these concerns are addressed. They are proved definitively to be of more benefit than harm. Until that point, we perhaps should, I believe we should suspend the vaccines, these COVID vaccines, and answer these questions. 54 publications requiring answers. And until they're answered, I won't be having any more mRNA vaccines. But that's just me. look at the evidence yourself, interpret it as you see fit. We don't tell you what to think, but we do provide evidence. And to my mind, the evidence is overwhelming. It's time to stop these until we know one heck of a lot more. In fact, I think we probably know enough to... It's hard to see that we need more research now. I think this research is pretty definitive. But we'll leave it at that. Let me know what you think. And as always, thank you for watching. And again, we're hoping more data is going to be coming out pretty soon. This is 54 publications from people that have taken the bother to write the publications themselves, basically. Hopefully we'll be getting more US government sanctioned publications really quite soon. This time, genuinely, thank you for watching.